As mentioned, the topic for this session encompasses transplant immunology and choosing the best match for kidney transplantation. Now, as you can imagine, in 20 minutes, there is a limit on what we can cover. So I've chosen today to give a broad overview of some of the immunological factors that are taken into account when considering a living or deceased donor kidney transplant offer. Our discussion today will by no means be exhaustive, but I hope to provide a framework with which to consider the complex interplay of competing factors. I have no disclosures, and I'd first like to start with a case, a couple of simple cases to get us thinking about how we might approach a transplant offer from an immunological perspective. The first case is of a 24-year-old man who had recently been diagnosed with end-stage kidney disease secondary to all ports. He had no other significant past medical history, and he was unsensitized, that is, his panel reactive antibody, or PRA, was 0%. His father, who was a healthy 48-year-old man, came forward as a live donor. Initially, this was intended to be a preemptive transplant. However, as COVID had just struck and shut down all of transplant activity in our area for a period, he ultimately commenced hemodialysis a few months prior to his live donor transplant. This was their match, and perhaps it's a bit small to see, but they are blood group incompatible, the donor being blood group A1 and the recipient being blood group O. There were no donor-specific antibodies identified, and the T and B cell cross-match was negative. This part shows the donor and recipient HLA typing, and at this bottom part of the screen, you can see the allelic differences. And as expected, they're a haplotype match, as they are father and son. And here the eplet load is given. 13 eplet mismatches at class 1, 1 class 2 eplet mismatch to give a total eplet mismatch load of 14. And we'll go through each of these elements shortly. In the second case, we have a 75-year-old recipient who has end-stage kidney disease secondary to IgA nephropathy. And during the course of her monitoring and transplant workup, she was diagnosed with first a localized renal cell carcinoma and then an early breast cancer, both of which were treated but delayed her access to transplantation. Consequently, she had been on dialysis for 8 years by the time she received a kidney offer. She was blood group O, and due to her 5 pregnancies, she was moderately sensitized with a PRA of 59%. She received a deceased donor offer via the donation after circulatory death pathway from a 59-year-old male. And here was their match. Both of them were blood group O. There were 12 HLA mismatches, 5 of these at the A, B, and DR loci. And there was a weak class 1 DSA with an MFI of 810 in the most recent pre-transplant serum. So what does this all mean, and how do we decide whether these are good matches and whether to proceed with these transplants? When considering a particular transplant offer, I like to break the process down into what are the competing risks for this particular patient and this particular match. Now, I'm going to focus most of our time on the immunological risks of rejection and development of de novo DSA, both of which increase the risk of graft failure and limit future transplantation. However, it would be remiss of me not to briefly mention the competing risk of remaining on dialysis. And as we all know, mortality on dialysis is up to 100 times that of the general population, particularly for our younger recipients. And dialysis mortality increases with increased time on dialysis. This particular graph is from Australian data from the ANZ data registry. However, similar trends have been repeated around the world. And you can see that the annual death rate is 10% for those who have been on dialysis for 1 year, and increases approaching 20% for those in their 4th or 5th years on dialysis. And we also know that kidney transplantation offers a survival benefit for suitable candidates compared to remaining on dialysis. So we need to always consider what the implication of rejecting a transplant offer and remaining on dialysis would be for our patients. I'm sure you're all familiar with this graph that demonstrates the survival benefit associated with transplantation compared to dialysis. But to realize this survival benefit, patients need to survive at least the first 3 months post-transplant, during which there is an increased risk of death. And in those first 3 months, the leading cause of mortality shown in this first 3-month panel here is still due to cardiovascular events, despite a reduction in cardiovascular risk over the eras. That being said, when we talk about choosing the best match for our recipients, we are really trying to maximize our transplant survival. Obviously, the patient has to survive for the grafts to survive. However, when we look at death-censored graft survival, we can see that short-term survival has improved over recent decades, yet the rate of attrition beyond the first year post-transplant remains largely static. In this Australian registry graph of transplant survival by era, the slope of the lines representing each era, which is the rate of attrition, are almost parallel after the first transplant year. And the most common cause of death-censored graft failure beyond the first year post-transplant is rejection. As you can see from this histological study of death-censored graft failures by Solaris et al., where antibody-mediated rejection was the most common finding on histology beyond the first year and accounted for over 60% of late graft failures. So to maximize graft survival, we need to reduce the risk of rejection and in particular, antibody-mediated rejection. So how do we do that? Well, that is of course where matching comes in, since we know that the degree of compatibility or incompatibility plays a crucial role in transplant outcomes. Now, compatibility can be described on several levels, including the number of HLA whole antigen mismatch, the presence and amount of donor-specific antibodies, and more recently, the concept of eplet mismatch is under investigation. And I'll briefly go through some of the data supporting the use of each. But it all starts with HLA, which, as you recall, is our main mechanism for delineating self from non-self. And in the context of transplantation, antigen-presenting cells present fragments of donor HLA molecules to the T-cell receptor, which leads to T-cell activation and an alloimmune response. HLA mismatch is therefore a key driver of the alloimmune response, and the degree of HLA matching plays significant roles in transplant outcomes. In this Australian registry analysis of over 8,000 recipients, higher HLA mismatch along the x-axis here was associated with increased odds of rejection. And in this right panel, higher HLA mismatch was associated with reduced graft survival, and although not shown here, with reduced patient survival as well. And of course, for this reason, organ allocation algorithms around the world routinely prioritize recipients with better HLA matching, all else being equal. This is true of the Australian guidelines on organ allocation, which are shown here, and similar principles for prioritizing HLA matching exist around the world. So how does HLA mismatch lead to rejection and graft failure? Well, as mentioned earlier, in the 3-signal model of T-cell activation, donor HLA is presented to the T-cell receptor within the context of MHC, and that's signal 1. Appropriate co-stimulation signals are required, which is signal 2, and when that occurs, there is positive amplification of IL-2 production, which is signal 3. This leads to T-cell activation and proliferation, which then causes cell-mediated graft injury via NK cells and cytotoxic CD8 response, termed T-cell mediated rejection. T follicular helper cells are also activated in this process, and these travel to the germinal centers of lymph nodes where donor-specific T follicular helper cells activate donor-specific B cells, which to become donor-specific plasma cells and therefore produce donor-specific antibody. These donor-specific antibodies travel to the graft where they mediate complement-dependent and independent injury on the graft termed antibody-mediated rejection. And we now know that it is the degree of preformed donor-specific antibody in the recipient serum that determines cross-match positivity and HLA incompatibility. In this multi-center US study of 10,000 living donor transplants, over 1,000 were HLA incompatible, as defined by positive CDC cross-match in yellow, positive flow cross-match in green, and the presence of donor-specific antibodies in red, also called Luminex positivity. And you can see that higher degrees of HLA incompatibility were associated with both increased graft failure on this left panel and increased patient mortality on the right panel. And again, while we often transplant across low-level pre-transplant DSA out of necessity, observational data suggests that increasing levels of Luminex positivity, as measured by MFI, is associated with increased antibody-mediated rejection and decreased graft survival. In the single-center French cohort study on the left, the risk of graft failure increased with increasing MFI of pre-transplant DSA. And on the right panel from a population-based German cohort, even at MFIs less than 3,000, there was an increased risk of ABMR and decreased graft survival. For recipients who develop de novo DSA after transplantation, there is also an increased risk of graft failure, whether this is initially associated with ABMR or not. In this Canadian cohort study, de novo DSA associated with clinical dysfunction, shown by this red line in the top panel, had the most rapid graft failure. However, those with de novo DSA without clinical dysfunction, shown by this blue line, also had decreased graft survival compared to those who never developed de novo DSA, shown at the top in green. After detection of de novo DSA, 70% of grafts failed within 5 years in recipients with ABMR at the time of de novo DSA detection, shown in this bottom panel in red. And in blue, those with de novo DSA without clinical dysfunction at the time of its detection also had a 40% graft loss at 5 years. And the mechanism of de novo DSA leading to graft failure is still likely to be through antibody-mediated rejection at some point. In the Sydney cohort, those with de novo DSA were twice as likely to develop ABMR, and we know that ABMR is the leading cause of late graft failure. As a result of this strong association between development of de novo DSA, antibody-mediated rejection, and late graft loss, factors which have the potential to minimize the risk of de novo DSA development have been closely investigated, and one of these factors is eplet mismatch, which we'll discuss now. So what are eplets? Eplets have been described as the smallest functional unit within the HLA epitope that determines the strength and specificity of donor-specific antibody binding. Let's go back to our little schema of the HLA molecule. The molecule is a membrane-bound protein with alpha and beta subunits, which form a peptide binding groove in the distal surface of the molecule. The HLA epitope is the physical site that a donor-specific antibody binds to on the HLA molecule, and it encompasses the distal surface of the molecule around the peptide binding groove, as well as the peptide itself, represented by the red line. Let's now take a top-down view of the HLA molecule depicted here as a three-dimensional model of the amino acid structure. The alpha subunits at the top are shown in pink and the beta subunits are shown in blue. The collection of brown amino acids in the middle here, although a bit hard to see at this resolution, are the antigen peptides within the peptide binding groove. And surrounding the antigen peptide are clusters of amino acids in yellow. And these represent the sites of amino acid polymorphisms within the HLA epitope. And it is these clusters of polymorphic amino acids within the HLA epitope that play an influential role in the strength and specificity of antibody binding. These polymorphisms were termed eplets, and each different polymorphism or eplet was given a name that corresponds to the amino acid sequence number and the change in amino acid sequence. Each HLA antigen is therefore made up of a unique combination of eplets, although the individual eplets themselves may be present on more than one HLA antigen. And this is what leads to cross-reactivity. Antibodies are not recognizing the whole antigen, but individual eplets. Therefore, an antibody to the square eplet on antigen 4 will recognize the square eplet on antigen 3, even though these antigens may be from different loci. So eplets provide a higher resolution framework for considering HLA mismatch. Now, in my opinion, the evidence for use of HLA eplets in transplantation is not yet fully formed. However, there is consistent retrospective observational data, albeit with significant limitations, that nevertheless suggest an association between eplet mismatch and the development of de novo DSA, as well as the incidence of T-cell mediated rejection, ABMR, and ultimately graft failure. An example is this retrospective Belgian study, which is population-based. However, similar findings have been reported in US cohorts as well as single-center Canadian and Australian studies. As I said, I don't think we have come to a good understanding yet on what the role of eplets are or how they should be used. Eplets are theoretical constructs, some of which have been verified by the presence of antibodies which therefore delineate immunogenicity. However, I think to consider simply the summation of eplets does not utilize the full potential of the information provided. Now, before I go back to our cases, I just want to say a couple of things about ABO incompatibility, as it is obviously important and relevant to our case. It's a whole talk in itself. However, it's just worth noting that ABO transplantation has excellent outcomes in experienced centers, with 96% graft and 98% patient survival at 1 year. However, as shown in this meta-analysis, despite these reassuring, although short-term outcomes, the risk of graft loss is significantly higher than incompatible grafts, which is not surprising. There is also an excess of rejection and viral infections, and ABOI transplantation is, of course, a higher risk procedure than ABO-compatible transplantation. That's all I'm going to say about that, and with that, let's return to our cases. So in our first case, there is a medically uncomplicated recipient and live donor. They have a low number of HLA and eplet mismatches for what that's worth, with no donor-specific antibodies, but they are ABO incompatible, which confers an increased risk. We measured the anti-A1 titer, which was low at 1 in 8, and given he was young and likely to need a further transplantation in the future, we opted to maximize the HLA and eplet mismatching to prevent sensitization. And we went ahead with the ABO incompatible transplant with some desensitization treatment. He's now 4 years post-transplant with a creatinine of 130 and doing well. And in our second case, we had an older comorbid recipient, though without any cardiovascular history, who was moderately sensitized with a relatively high number of HLA mismatches in this DCD donor and a weak class 1 pre-transplant DSA. For this patient, given her age and dialysis vintage, time was of the essence. We came to the conclusion that her risk of mortality on dialysis outweighed the risk of ABMR due to the low-level DSA, and we went ahead with the transplant. She did indeed develop early ABMR, requiring treatment, but has since stabilized and is now 10 weeks post-transplant with a creatinine of 200. So to summarize, organ matching is performed to maximize graft and patient survival by minimizing rejection. HLA whole antigen matching, donor-specific antibody, and eplet mismatch are different aspects of assessing transplant compatibility, and all are associated with important transplant outcomes of rejection and graft survival. Assessing a kidney transplant offer is a risk-based risk-benefit analysis that needs to be individually undertaken for each given recipient and transplant match. And I'll stop there and thank you for your kind attention.
The talk is on optimizing immunosuppression. This is a huge topic, so I will be only giving strategies and tools that will help you optimize and personalize immunosuppression. I will not be going through each individual clinical trial, but will be giving a summary of findings from large clinical trials. So the key principles of immunosuppression in transplant is related to the use of multi-drug immunosuppressive regimen, which targets multiple steps in T cell activation. This is so that lower doses of individual medications can be used to aid decrease in drug-related toxicities. The other key principles that are being used are to use induction therapy in conjunction with high-dose maintenance immunosuppression during the early post-transplant period, whereas in the late post-transplant period, you try and lessen the maintenance immunosuppression appropriate for an individual patient. Of course, there's management of rejection episode that comes both in the early and the late post-transplant period. So the overall conundrum that a clinician faces is to balance between over-immunosuppression, which could result in drug toxicity or infection, and on the other hand, balance rejections. So induction therapy in transplant is performed in almost 92% of all kidney transplants worldwide. They use either a depleting protein or interleukin-2 receptor blocking antibody along with maintenance immunosuppressive agents. The benefits of using induction agents are it reduces the rates of acute rejection, improves 1-year graft survival, and also helps in allowing tailored regimens like delayed initiation of CNI or corticosteroid reduction or withdrawal. So these are the usual induction agents. Basiliximab is the IL-2 blocker. Anti-thymocyte globulin and alemtuzumab are the depleting proteins. And these are the suggested doses, but each transplant centers have their standard protocols. Basiliximab is a chimeric monoclonal antibody that blocks CD25. It inhibits the activation of lymphocytes, and a cumulative dose of 40 milligram of basiliximab can saturate the CD25 receptor up to 8 weeks. It's quite well-tolerated drug. Coming to depleting proteins, there are 3 commercial preparations available for anti-thymocyte globulin: equine, ATG, and rabbit anti-thymocyte globulin, as well as rabbit T lymphocyte globulin. The equine anti-thymocyte globulin has gone out of favor because of its inferior efficacy compared to the rabbit preparations. The mechanism of action is through T cell depletion. It causes apoptosis and antibody-dependent cell-mediated cytotoxicity, as well as opsonization and phagocytosis by macrophages. The immune reconstitution can take several months to return to the baseline levels, and this needs to be remembered. But rabbit preparations can also preferentially help in the expansion of T regulatory cells compared to effector cells, as inducing long-term immunomodulation. So what are the optimal dosing strategies that are available for this rabbit ATG? The full dose that's usually recommended is 3 to 6 milligram per kg administered over 2 to 4 days. One of the strategy is to monitor CD3 T lymphocytes, and if that is less than 0.05, then it will help us to titrate the doses downwards. The other surrogate for monitoring CD3 T lymphocyte is total lymphocyte count, and this is especially useful when there is lymphopenia, that is, the total lymphocyte count is less than 0.3. But in cases where there's no lymphopenia, it is more wiser to monitor CD3 T lymphocyte to titrate the doses of ATG. The other strategy is to titrate the dose based on a myelosuppression of the white blood cell counts as well as the platelets. The third tool that we have to optimize dosing strategy in rabbit ATG is to look at the immunological risk. And based on whether it is a standard risk living donor or a standard risk disease donor or a high risk immunological risk recipients, the doses can be increased accordingly. But keep in mind that more than 6 milligram per kg of cumulative dose leads to increased infection, malignancy rates, and greater risk of serum sickness. Whereas, on the other hand, less than 3 milligram per kg of cumulative dose does not effectively prevent acute rejection. The next dosing strategy for rabbit ATG is to time it with intraoperatively. Again, intraoperative use of ATG compared to postoperative helps in reducing the incidence of delayed graft function as well as decreases the length of stay, hospital stay post-transplant. The other depleting protein that is currently used is alemtuzumab. It's a monoclonal antibody directed against CD52 receptor present virtually in all immune cells. It causes profound lymphocyte depletion through antibody-dependent cell lysis, but the immune reconstitution here takes more than a year to reach baseline levels, and it's not approved for use in transplantation. When used, it is used as a single dose of 30 milligram on post-op day 0. There are some centers which use a lower dose of 20 milligram. The main concerns with this molecule is that it causes a significant IL-21-driven autoimmune response, and this happens during the immune reconstitution phase and leads to higher rate of antibody-mediated rejection. Also, there are higher rates of serious infectious complications and leukopenia. Any other tools that are available to further optimize induction therapy? It has been shown that if transplant recipients have a polymorphism to a TNF-alpha gene and they are not induced with rabbit ATG, they are at a higher risk of rejection. The choice of induction agent again depends on whether the recipient is of low or high immunological risk. The choice of induction agent also depends on the plant maintenance immunosuppression protocol. For example, if you're using tailored approaches like early corticosteroid withdrawal, it will be wiser to use a depleting protein. The other factors that should be considered to optimize induction therapy are history of malignancies, significant infectious diseases like hepatitis and retroviral infections, and cumulative lifetime exposure to immunosuppression in conditions like SLE. Maintenance therapy in transplant. Again here, the gold standard maintenance therapy is tacrolimus, mycophenolate, and corticosteroids. That's because in several studies, it's shown that the acute rejection rates are minimal and there is a good 1-year allograft survival. But many transplant centers around the world, in order to reduce the overall immunosuppression exposure, are exploring different transplant protocols like lower TAC exposures, early corticosteroid withdrawal or minimization, CNI-free protocols, or even substituting mTOR for antimetabolites. So these are the commonly available maintenance therapeutic immunosuppressive agents. We have cyclosporin and TAC as CNIs. We have azathioprine and MMF as antimetabolites. We have mTORs, which are sirolimus and everolimus, and the backbone of all transplant programs, which is corticosteroid. As you would have seen from the previous slide, most of the dosing is weight-based. But weight-based dosing is not precise and does not predict the drug handling. So you need a better way to predict efficacy and safety. And especially with CNIs, which has a narrow therapeutic window, therapeutic drug monitoring is a strategy. And whole blood trough levels are good enough for predicting for correlating with efficacy and safety. So a low concentration to dose indicates that the drug is rapidly cleared, leading to enhanced risk of death-censored graft loss. What about pharmacogenomics? P-glycoprotein is a protein that's involved in the transport of CNIs. CYP3A4 and CYP3A5 genes are involved in the CNI metabolism and clearance, and variants in this gene have been associated with alterations in their metabolism. Especially with CYP3A5 gene, STAR1 allele, at least the presence of one allele confers the recipient as an expressor or a rapid metabolizer status. This polymorphism is very common in Asians, and if it is present, then you require at least 1.5 to 2 times higher dosing to attain similar overall exposures. The Clinical Pharmacogenetics Implementation Consortium, that is a CIPIC body, has recommended individualized TAC dosing based on the CYP3A5 phenotype as extensive metabolizer, intermediate metabolizer, and poor metabolizer. But has this translated to good clinical outcomes? There have been 3 randomized clinical trials that have evaluated the clinical outcomes of pharmacogenetic guided TAC dosing and has not found any significant benefit compared to fixed dosing. That's because these trials have looked at achieving a proper initial tag dose. But what is imperative is not just to have an proper initial tag dose, but also to keep patients within the therapeutic range after the initial post-transplant period. And not many clinical trials have looked at the long-term impact of pharmacogenetic guided tag doses. So the CIPIC recommendation right now is not a routine pharmacogenetic-based tag dosing, only to be done if the individual's genotype is known. What about non-genetic factors? So there are a lot of non-genetic factors that can affect drug handling, like age, sex, kidney or liver function, plasma albumin concentrations, hematocrit, body surface area, or concomitant medications. Population pharmacokinetic modeling generates dosing algorithm that combines both genetic and non-genetic factors. Beyond this, we also need to keep in mind that there are new formulations that will help you optimize immunosuppression, especially with regards to tacrolimus. There are two extended release preparations. One is the LCP TAC, which uses a melt dose technology and improves and the TAC is mostly absorbed in the lower GI tract, and it bypasses the upper GI tract where most of the metabolizing enzymes are present. The other formulation is the TAC granules. This helps in dosing TAC to the 10th of a milligram, and it is especially useful to optimize immunosuppression in pediatric patients. Now, coming to anti-proliferatives as maintenance therapy. Again, here the gold standard and tried and tested drug is mycophenolic acid. There are two preparations. The enteric preparation is to improve the upper GI adverse event profile of MMF, and then there is a mycophenolate mofetil. Just to remember that MPA is teratogenic, so in a pregnant patient, obviously you will choose the inferior alternative, which is azathioprine. MPA again has fixed dose regimen as well as concentration controlled regimen. Here, as opposed to CNI, it is not the trough level that is the best tool. It is the area under the curve that is the best tool for monitoring MPA. And it does correlate strongly with acute rejection, adverse events, and infectious complication. But has it really translated to clinical outcomes? There have been at least 4 large RCTs which have looked at fixed dose versus concentration controlled dosing, and there are conflicting reports on renal outcomes. So again, TDM for MPA may be suitable in tailored regimens like CNI minimization protocols or to be considered in high-risk patients. Where do we stand as regards to pharmacogenomics in MPA? UGT1A9 is a gene which helps in the biotransformation of MPA to MPA glucuronide. ABCC2 is a gene which helps in drug transport and biliary excretion, but studies in the genetic variants of both the genes have shown contradictory results in kidney transplant recipients. There's a gene called HPRT1 which encodes hypoxanthine guanine phosphoribosyl transferase, and CIPIC does recommend testing for this gene because if the patient is deficient in this enzyme, then we may have to use an alternative antimetabolite. Now, coming to azathioprine as maintenance, again, azathioprine is a prodrug. The active drug is 6-mercaptopurine. Now, if there is the toxicity of 6-mercaptopurine on bone marrow will increase if there is a variant in TMPT gene, which will interfere with the thiopurine methyltransferase enzyme, or if there are drugs that can inhibit xanthine oxidase. There are alleles in the TMPT gene, both heterozygous and homozygous, that can classify the recipient as slow metabolizer. And if they are slow metabolizers, then we need to give a low initial dose of AZA or consider using another antiproliferative agent. NUDT15 is another gene that is responsible for thioguanine metabolism. Again, a variant called R139C is associated with significant myelosuppression. Recently, there have been increasing usage of co-stimulation blockade, which is belatacept, either as a de novo, de novo as a replacement for versus without CNI, or as a conversion from TAC. From the various clinical trials, what we have found is de novo belatacept causes significant reduction in HLA class 1 antibodies. but it does have a higher incidence of cellular rejection. There's no significant difference in renal function compared to CNIs. There's a lower incidence of post-transplant diabetes when compared to TAC, and there are improvements in blood pressure and lipid profiles compared to CNIs. The scenarios where belatacept can be used, where TAC can be converted to belatacept, are when there is a TAC-induced nephrotoxicity or TMA, when there's impaired allograft function, delayed graft function, or atypical HUS. Belatacept does come with a FDA black box warning of increased risk of PTLD, hence it needs to be avoided in patients who are Epstein-Barr virus naive. I did say that belatacept causes increased risk of acute cellular rejection, and this is found in individuals who have the presence of CD28 positive memory T cells. So perhaps the presence and quantity of CD28 positive memory T cells could be a potential biomarker for response of belatacept. Coming to mTORs, which are everolimus and sirolimus, again like CNI, it's a whole blood trough level which is useful for monitoring the therapeutic concentrations. There have been many clinical studies which have used everolimus and sirolimus either as CNI sparing regimens or as a replacement of the metabolite in combination with low-dose CNI. Overall, there's no significant benefit in patient or allograft survival or allograft function. And keep in mind, mTORs do have a large adverse event profile. So what are the situations where it could be potentially useful? Certain malignancies like basal cell carcinoma, squamous cell carcinoma, lymphoma, and renal cell carcinoma, mTORs could be useful because it has anti-angiogenic properties and it decreases VEGF. It is useful in resistant or recalcitrant CMV infections. And CYP3A5 is involved in the metabolism of mTORs also. So a STAR1 polymorphism can label the patient as an expressor or a rapid metabolizer, and it will require titration of mTOR doses. Now coming to the backbone of all transplant program, the biggest concern with corticosteroid is that when it is used in the usual standard dose of a long duration, there is a significant adverse event profile. And hence, many transplant programs have gone on to use corticosteroid avoidance or corticosteroid withdrawal regimens. Overall, there's no differences in patient or allograft survival or function, but the risk of acute rejection is higher, especially when the corticosteroid is withdrawn for less than 14 days post-transplant or in the late post-transplant period. There's been no significant difference in the rate of infection and malignancy. So now the recent trend is to lower the dose of prednisolone as quickly by day 7 to 5 milligram in low-risk patients rather than complete avoidance or withdrawal. These are the various future agents that are in various phases of clinical trials, and I'm sure once they come into clinical use, they will further help you in optimizing your immunosuppression. So what are the challenges with traditional immunosuppression in transplant? They have narrow therapeutic indices. There's the impact of genetic, non-genetic factors. There's lack of satisfactory in vivo testing to determine the degree of immunosuppression borne by individual patients. And the adverse event profile demands intense post-transplant follow-up. Hence, the eternal quest for transplantation tolerance. And the most successful approach to date is through the induction of immune chimerism through concurrent bone marrow transplant at the time of kidney transplant. But the new tolerogenic strategy that has great potential for clinical use is the use of T regulatory cells. T regulatory cells can be stimulated by multiple pathways, and they can cause immune suppression again by multiple complementary pathways. These are either contact dependent or contact independent. There are generally three approaches for the use of Tregs. One is the in vivo enhancement of Treg expansion, either by using low-dose IL-2 administration or mTORs. The other is specific deletion of effector T cells to alter the overall ratio of Treg to T effector cells. And the third is the most advanced ex vivo expansion and adoptive transfer, where you can have precise dosing and specific allograft-specific targeted immune suppressive effects. And there are currently studies ongoing in this regard. Chimeric antigen receptor Tregs, these are the most evolved of Treg. CARs are synthetic receptors that are artificially expressed in T cells and genetically modified. They can be used to target allogenic tissue and provide antigen-specific immunosuppression locally. Again, there are clinical trials going on in this regard. There are many biomarkers that have potential for clinical utility. There are many marketed tests, both in the pre-transplant and in the post-transplant scenario, for detecting antibodies as well as cellular immune responses. The newest one is the TTVI watch, which is a torque-tenovirus, a circular single-stranded DNA virus that's commonly present in all human body fluids and does not cause disease. So the viral load in plasma will indicate the overall net immunosuppression in the recipient. And if we are too overwhelmed, then you can harness the power of artificial intelligence. And these data could be fed, and AI-powered algorithms will help you in personalized care in kidney transplant. Thank you.
Before I start, I would like to take a vote. If this was the debate, and this is the topic given, kidney transplant is the best mode of renal replacement therapy for end-stage kidney failure patients. How many people will vote that this is the best mode of treatment? Almost everyone, right? So this was the motion in 1989 when I was a senior registrar, and by default, I had to talk in a debate with one of my mentors. He was a transplant surgeon who was going to talk in favor of this motion. And the person who was going to talk against this motion was also my mentor, who at the last moment was off sick. And as a senior registrar, you don't have any choice. You're told that you're going to talk. And what you would talk, so I had to talk against the motion, which I did believe that this is the right thing. Now, this is the lesson for the trainees, that when your wall is against the wall, or when your back is against the wall, you are in deep trouble. At that time, you sometimes come out with creative thinking. So now I have to talk against something which I believe in. And this is the way I started my talk. And I said that renal transplant is an extended interval between two dialysis stations in patients with end-stage kidney failure. And I think that sums up what we have heard from you two and what is happening today. That very rarely you see a patient who has got kidney transplant which lasts for his life. By that I mean that it goes for 40, 50 years. If you've got a 20-year-old guy, almost certainly he will end up getting 3 transplants. Very rarely it will last for his lifetime unless he dies very prematurely. So we need to make that transplant last for his life. So that is the thing which is very, very important. When I was at that stage, I had to convince the audience that what I'm saying is right. Before cyclosporin, which is well before I was even a medical student, I was a medical student when cyclosporin came in, the graft survival was measured as a functioning graft on discharge post-operation, which is the prednisolone and azadase. So the graft survival was so poor that they used to measure their graft survival as graft functioning on discharge. Post-cyclosporin, we started measuring long-term graft survival. So we owe it to cyclosporin that this sort of a data started coming, and they started looking that the graft survival is not only after discharge, what it is in 1 year, 5 years, 10 years. So this is our statistical colleagues who are still very active. They design the study, they do the statistical analysis. They were telling us way back that the graft survival in 1988, they were predicting that it will be 7.9. It will go to 8.7 the subsequent year. This is the data by the statistical estimated survival. And this is half-life. we still use half-life of a graft. I don't know why not absolute survival, but anyway, this is the way it was invented and is still in today. This is the estimation graft survival. They are getting very better, but the real-time graft survival hardly moved. So that was a disconnect between what our statisticians were telling us and what actually we were seeing it on the ground. So that has not moved. Because at that time, and still today, most of the graft management is immunocentric. We just don't want the rejection to happen in the kidney, no matter what. Rejection-free survival is what we are looking. The drugs are being developed to have rejection-free survival, and it is immunocentric. And as we have heard, that the better the matches, the longer the survival. And this is CTS data from Gerhard Robles, who was my collaborator, has retired now. This is the data was emerging from CTS registry, that the better the graft survival is better with full house match as compared to those which were not fully matched. And life was very easy, believe me. When I was a registrar, senior registrar, life was very easy, okay? We had fit young patient who would be the recipient. We had fit young donors, and we had one-size-fit-all strategy, which is to some extent is applicable today. We used cyclosporin, we had no MMF, so we used azathioprine and steroid, and we were happy. But this was all to change when I became a consultant. So that's a bad luck. When you become a consultant, something changes. So this study published from America, which changed the landscape and the map of transplantation. It was an observational study, but it caught the eye of every transplanter in the world. And I'm not going to go through the whole study. It is an observational study. And it's the first time somebody gave the numbers. So that if you are a patient waiting on the transplant list, your annual mortality was 6.3%. If instead you got a kidney transplant, it went down to 3.8%. So this was the first time anybody said that transplantation lowers the mortality in a similar group of patients who are on the waiting list, because waiting list patients are similar in comorbidities, etc. So they were lucky to get the transplant, but those who were unlucky, they were waiting. Transplant gave a survival advantage. And guess what? The survival advantage was maximal in the two groups of people which we never considered for transplantation: type 2 diabetics and elderly recipients. So those people who were excluded in many programs, they had the best survival. Rather than waiting for transplant, they got the transplant. So, huge paper, even though it's an observational data. Second thing I'll point out, at that time, the dialysis survival of the America was worse than anywhere in the world. So this is American dialysis survival on waiting list compared to getting a kidney transplant. Okay, that data has not been repeated in Europe or any other country like Japan, where they've got the best survival on dialysis. But it was good. So one size fit all became like this. Everybody wanted a kidney. Okay? Today, this woman who has got one leg in the grave and one on the banana skin still would like to take that, am I eligible for transplant? So recipient pool has changed. What we do? Everybody wants a transplant. So we started putting them on the transplant waiting list. Transplant list started exploding. So we were forced into accepting what we never thought when I was a registrar or junior consultant, to open the door for donors as well. So we started accepting really marginal donors who would have never met the cut when I was a registrar. And we had to then go and subclassify these donors. So there were standard criteria donors, which what I was used to. So I had to retrain to look after kidneys coming from these highly comorbid marginal donors or extended criteria donor, or those who have been a donor with circulatory arrest. And most of the kidneys now get pre-implantation biopsies, and we have got better tools now to give some sort of a risk stratification of the kidney which we are putting in our patient. And these are called KDPI scores. These are the things which go in before the kidney is accepted. And the higher the score, the poorer the quality of the kidney is. And the survival is reflected in this. So this is still the half-life. Now this is 21st century. It is 2020. The living donor half-life is 12 years. These are live donors. And standard criteria or expanded criteria, the graft survival goes down. So we have not improved from 1980 or 1990. Long-term survival had hardly changed. Now the focus is on quality of kidney. And for those who do disease donor, the rejection we've already got control. As we heard from Dr. Alexander, we just hammer them with the lymphocyte depleting antibody. Whatever you give, you don't get rejection. Rejection is a stigma for a transplant unit. So we have got over it. But for these kidneys, they are now giving us delayed graft function. Kidney doesn't work for weeks before they work. Has got any problem, and it is now becoming clear that these are the kidneys who not only reject, but they give you poor graft function. So there's a lot of effort now being made to look after the kidneys rather than the recipient. Before the kidney comes in, we need to look after that kidney. The organ retrieval should be as good, because these kidneys, if they're poorly retrieved or they're coming from a marginal donor, they are programmed to develop fibrosis. There are a lot of regimes. One was alluded to, that you can delay the CNI introduction if you can give lymphocyte depleting agent, but I would say that the clinical trials did not show that they did prevent delayed graft function. I have a benefit study, which was belatacept study. Patients who never saw CNI, they got the same level of delayed graft function as those who got to CNI. It is the donor and how you retrieve the kidney and how it is transported. And this is now 2024. People are beginning to think that the way we move the kidney from one center to other on ice static is bad news, particularly for marginal donors. They should be on a perfusion machine, being perfused with hypothermic solution, and even with oxygenated hypothermic solution. So that is the future, that we would be moving these marginal donors. The other way to protect these kidneys, and we've done a lot of work in this area, is to do some preconditioning of these donors before you retrieve the kidney. And this is the study published in New England Journal of Medicine, where they just drop the temperature of the donor by 1 degree. Then they retrieve the kidney, thinking that if we retrieve the kidney before any damage has happened, it will relate to better graft outcome. And yes, the delayed graft function was almost halved just by doing one. Before retrieval, the temperature of the donor was dropped by 1 degree. It's a randomized controlled trial. And those which had the ECD, where usually the delayed graft function is 60%, they lowered it down to 30%. So let's go into the causes of long-term graft loss. We have succeeded by 5 years. What happens after 5 years? And I think this is where the battleground should be. We don't know. Many patients die. I can't stop somebody dying. So you need to choose your recipient well. But there is a thing that is the quality of life. If he wants to have a 5 years free of dialysis, but he dies, that is quite acceptable. But remember, the kidneys are not growing on the tree. It is a very limited resource. So we need to be quite careful in who will benefit most from that limited resource. So that debate will go. That is an ethical debate. But one of the things which came from Australia and from my friend Jeremy Chapman, that in 2000, he published a paper for pancreas and kidney transplant, saying that 90% of his patients, when they did a kidney biopsy at 1 or 2 years, had CNI toxicity changes in the kidney. That led to a slight fundamental shift in the use of CNI and people started to use less amount of CNI. Symphony trial was conducted, which was 1-year study, and they said that you can reduce the trough level of tacrolimus and still get very good results. So that's the phase we went through, that CNI is the cause of long-term graft or CNI toxicity, which I say that when I was a registrar, I had patient with PRED and ASA, they got the same histological change, which what we regarded as CNI. So it is a stereotype response of a kidney which developed IFTA, and we just label different names. So this had to be clarified. A big study was done with the late kidney biopsies and was reviewed by 25 histopathologists. They scored it, and they came to the conclusion that arterial hyalinosis or striped fibrosis, which was regarded as CNI toxicity, in fact, they had the best graft survival as compared to those who did not have these changes. Now, that was a fundamental hole in the theory of CNI toxicity. Then came a molecular microscopy, and Phil Helleran, again, a collaborator and a friend, he did transcriptome work to find out how the kidneys are failing. And the transcriptome work clearly showed different pattern of injuries. I alluded to in my first talk that this is how the future will be, but he applied this molecular microscopy, and in fact, it is now commercially available. You can take a sample and send it in a frozen section to him, and he will give you not only the transcriptome, but also the result and interpretation of that, which is better than cold histology. What did he find? That he could group them, that antibody-mediated rejection, T-cell mediated rejection, you could get all those changes. And his conclusion was that over 50% of the graft loss is due to chronic antibody-mediated rejection by molecular microscopy. And I think that has not been mentioned so far. He went back to all these patients and found that it was common in those who self-confessed being poorly compliant. We don't pay much attention to how much our patients dodge the issue and don't take the tablets. It is not to be underestimated. Poor compliance after a year or 2 and 3 becomes very common. And the people who are more drugs, they are the ones who are sadly poorly compliant. Just to confirm this, we just heard from Dr. Alexander that belatacept is associated with less antibody-mediated, or at least DSAs. It's not because belatacept causes that, it's because it is given supervised therapy. All the 7 years, they come for every 2 weeks or 1 month, get an injection in front of you. It is called supervised therapy, and that's why they don't get DSA. So what I said, poor compliance leads to DSA and chronic antibody-mediated rejection. It is proven by benefit study, long-term data, that they don't get, because belatacept has got no property to prevent antibody-mediated rejection. It's supervised therapy. Let's go to other things in which the nephrologist, we sitting here, should be expert. So what we can do to protect the heart, because the commonest cause of death in our patient and graft loss, working, and you have to bury 2 things. You bury a working graft and a dead body. How we can prevent that to prolong the graft survival? Almost 30 to 40% of my patients get diabetes post-transplant, and we would like to see if there is any evidence how best to manage diabetes. What should be the standard A1C in our transplant patients? I have not given any data because I don't want to embarrass you. There isn't one. There isn't a single proper randomized controlled trial to answer this question, that post-transplant diabetes, how should we manage it? What should be the level? Which A1C is better? What about statins? We use it in all your transplant patients. Is there any evidence that it works? This is alert study. Use fluvastatin because at that time that was the flavor of the month, and that was the drug company which funded it. So people still say that fluvastatin is a weak statin. That's why we didn't see any benefit. But look at it. LDL cholesterol went down by 32% on fluvastatin. You can see. So it did what it says on the tin. There was no difference in either graph or patient survival. So statin trial negative, we have not repeated it with better anti-cholesterol drugs. ACE inhibitors are the dogma. If I were to come and tell you that ACE inhibitors are no different from any other good antihypertensive drug, provided the blood pressure is the same, you think I'm gone crazy. Really, you would think so. And the guideline bodies will tell me that even take his license away from nephrology. But if you look at the meta-analysis of ACE inhibitors in native kidney disease, in those where it was compared with the comparator, there is no difference in the outcome, both cardiac as well as renal. So, will it work in transplant? Randomized controlled trial, no difference. It's in front of you. These are proteinuric transplant patients, randomized to placebo versus ramipril, 2 years data, no difference whatsoever. Because we knew that blood pressure ACE inhibitors will not work in transplant. It's a different cause of hypertension. And this is thanks to one of my ex-registrar, Ben Walsh, who moved to Royal Free, became a professor of nephrology, went to Heights. He, with his collaborators in America, did very beautiful piece of work and showed that tacrolimus-induced hypertension in transplant is due to the acquired Gordon syndrome, which is the reverse of Gittelman's. You get upregulation of sodium chloride channel. The drug of choice here should be thiazide diuretic. It works. Try it. So I would say that I dedicate in the memory of my registrar. It still pains me. He passed away just a few months ago, and I just can't get over his sad loss. But we need to also remember those who are heroes of our specialty. Joseph Murray did he was the first one who did the successful transplant on 23rd of December, 1954, between two identical twins, Ronnie and Roderick. We need to remember Peter Medower, who described in 1950 how the rejection happens, which we heard from our colleagues today. He's the one who described every mechanism. We need to remember these three guys who were given Nobel Prize for discovery of HLA. And finally, I would like to remember my own mentor, who is still alive, Professor Rizvi, and it is because of him I became a kidney doctor. I met him when I was a third-year medical student. He didn't only teach me to be a good doctor, he is the one who taught me how to be a good human being first. A good doctor is one who is a good human being. And he taught me when I was a third-year medical student this: we cannot let them die just because they cannot afford to live because they cannot afford the treatment. Medical care is your birthright. This is what is close to my heart. Every human being in this planet deserves the same care and access to medical care, and that's what we should be aiming for.